And it's just a little bit to start for yourselves to start visualizing. If you were to start doing WBA, and for those of you who don't yet have WBA and might not even have EPAs, you want to start looking for opportunities to give feedback. And we will have a proper session on how to give feedback. And I realize we are all so busy. And we've seen now in family medicine that what ends up happening is our registrars become workhorses in our department. They spend the 4 or 5 years there, running our surgeries, running our after hours, running our clinics, our OPDs, and we're sort of making an assumption that because they're there and they're doing stuff that they're learning and that they're learning the right stuff. And I think we cannot actually get away from our responsibility that we do have to find a way to engage more with our registrars and see what they're actually doing, a little bit like that consultation you've watched. So there are 4 types of WBA that Ole Tenkate always describes, and that's described in the different literature. And I'm going to show you the 4 different types. And it depends very much on the discipline on which ones of these are the most practical for your setting. So there's no rules in which ones you want to use, but you want to use preferably some from each and have a good mix of different kinds of WBA. So the first one is the brief direct observation. So that's the one that we've just done. So that can be you actually sitting in on a consultation. And we've got there's tools, for example, one can use like the mini CX where somebody marks you while you're sitting in a consultation. You can watch or assist a procedure, and there's tools for that as well, which you can use, but you don't have to. But it can also be literally observing somebody doing a morning round presentation or presenting a patient on handover. It can be a lecture that's presented at your academic meeting. So any opposite situation where you are observing somebody will count as a direct observation. And we've had quite a bit of discussions at some of the groups around video observations. And video observations is very useful because we can't always be present. You're able to watch the video in your own time. But videos is also challenging because obviously they're slightly more set up. So they're not quite as granular as sitting at the workplace where things are happening. And there are obviously things that can be edited, and the registrar can be more selective in terms of what they send you. So I think videos are useful, but you don't want it to be only videos. So the trick with WBAs is have a mix. And if you've got a mix, you're able to sort of cover all the different things that you want to do. Our second one is we can do EPA decisions on longitudinal observations. So these are actually where you're looking, for example, at a whole rotation. So maybe your registrar has been farmed out to a different hospital or even a different province to go and spend a specific clinic or discipline that you don't have. And at the end of them, they meet with a clinical supervisor or that HOD. And what we want to do is we want to then provide that HOD with the EPA for that particular thing. So say, for example, my registrar has gone off and done anesthetics for a month. We want to make sure that the HOD and anesthetics knows that this is what is expected of them to be able to do. And then you can ask them to actually do an entrustment decision on that whole EPA after they have finished that rotation. And we have found this very useful playing catch up with our registrars who's now in their 3rd year. And for example, they did Ops and Gynae in their 1st year before we had the WBA. And instead of now trying to go and find lots of WBAs, you can actually get somebody who's observed them enough in the workplace that they say, no, this guy, I trust this guy's with anesthetics. I'll have him dope my mother, kind of thing. Another very lovely observation tool is the multi-source evaluation, which is a way to partly look at how people behave, because that was one of the questions that's come up. So how do you judge how somebody behaves, and how do you actually give feedback on that? So this is a JOT form or a Google kind of form that gets sent to a group of people in your department. Ideally, you want all your registrars to be doing that. I think all clinical supervisors should do that. And then you ask clinicians, nurses, other healthcare professionals, peers, you can even have patients. They then fill in this form to look at your behavior. And this is not going to look so much at clinical skills necessarily, but they're going to look at what we call professionalism features. So there are 4 particular professionalism features. There's a 5th one, capability, which speaks to clinical skills. But these have actually been identified as qualities we want our registrar to have to be able to be called a specialist. And we want them to have to display agency, reliability, integrity, and humility. And in our we've recently had a meeting on writing this book. We've now actually extended these to also include the 3 qualities of compassion, openness, so that speaks to diversity and non-judgment, and curiosity, which speaks to cultural competence and taking the context into consideration, as qualities that we want to see in these registrars. So the observers can be chosen by the trainee, but it happens you would say to the trainee, listen, we're going to do an MSF to MS multi-source evaluation today, and they decide who they send it all to, but it has to be across a whole range of different kinds of people, and the feedback is all anonymous, so you don't know who's given that particular feedback. It's not scores, more narrative, or and there's different ways of doing MSFs. So once you've got your multi-source evaluation, then you sit down with your registrar as a clinical supervisor, and then they need to reflect on what they have, what observations has been coming out of that. And one can potentially, depending on what you're observing, you can potentially do entrustment decisions on that as well. You can also have structured meetings where you are looking at specific aspects of performance and specific EPAs, sort of over like how you've been doing on minor procedures over the last 3 months in this department, and make entrustment decisions to that. Your third one, and for me, this is the really exciting one for those of us who are on very sort of more medical rather than surgical things, is what they call case-based discussions. So this idea is actually when you're not just observing, but you as a supervisor are actually actively testing their knowledge, their insight, and their anticipated action, as they call it. So this is typically a case discussion. And what's lovely about these is you can do them over the phone. So you can do them on phone or Zoom, and the registrar calls you up and say, listen, I've got this patient, and they present the patient to you. And actually in practice, this happens all the time anyway. And what we do is when they bring the discussion is, instead of just going straight into the answer or the advice, is you spend a little bit more time and you ask particular questions. So you firstly obviously find out what they've done, but then you try and figure out, okay, what do they know? What do they understand? Why did they decide to do that? And then we start asking wider questions about that particular topics. What would you have done in this scenario? What complications are you looking out for? And then you can look at in terms of widening the topic. So if they're discussing a patient on drug-induced liver injury, you can then say, well, what, for example, if this was a drug-resistant TB patient, what would you have done if the patient also has renal failure? What would you do if they've on these particular ARVs? And by doing a little bit of questioning, you can actually get a really good idea how well do they know that particular case topic that they've come to discuss. And then you can make an entrustment decision on that. In family medicine, a lot of our WBAs are all entrustment-based discussions. An interesting thing that Vanessa Birch brought up at our last meeting is that you can also do this on, combine this with a product review, which we'll talk about in a minute, but you can have an interrogation, for example, looking at somebody's surgical notes after, so you weren't present in the surgery. Now they come and present that case to you or something that's happened. They've got the file or the clinical notes of what's happened. And you can do the same thing, asking about, well, what would you have done in these scenarios? What were the complications you looked out for? What are the important things you need to check? And be able to actually make entrustment decisions on a particular thing without having actually observed that. So the fourth one is this product evaluation, and that's very helpful where you have sort of an outcome. So surgical would be, you know, if you're orthopedic, what the hip replacement looked like afterwards. If you've got a dental reconstruction, if somebody's done a CT scan report or is reporting on ultrasound images. If you're looking at a patient review, patient evaluation forms for all of our pathologists, if they've written reports on histology slides, for example. And it can also be observing, for example, a journal that they might have published or a journal that they might have had to analyze. So yeah, some people put observed presentations under direct observation. Some people put them under product evaluation. But all of these are a product that you can look at. And surgical notes was then one of the things that's come out. So you can either just look at the surgical notes and make an entrustment decision on how well they've done their notes for that particular thing, or you can then have that discussion and actually interrogate your registrar to get a better idea of their knowledge and understanding of that particular procedure. So we were talking recently for forensics, for example, J88s. You can, for example, then evaluate a J88 that's been filled in as a product evaluation and give them an entrustment decision on how well they have done that. So this also then, other things you can look at is, for example, logbooks. So logbooks we all still have in terms of the number of procedures of everything they have had done. But then you can actually have a meeting to look at their logbooks and evaluate how well their logbooks have been filled in, if they're seeing a breadth of different procedures, if they're up to date, and be able to actually make entrustment decisions on that as well. And then any written reports that they have to write. So some disciplines require written reports, and those are also things, all opportunities for WBA. So the idea, or maybe let's just, so we're not going to break into breakout rooms to talk about barriers and enablers, but just in terms of some of the questions that's come up, and then we'll have a last 5 minutes for a last few questions, is around the how do I do this in a busy department? So in practice, what's supposed to happen once you have formal WBA is we want the registrars to record at least 2 WBAs a week. And I have also found it's impossible for you as a consultant to try and chase registrars and to identify WBAs for them. So we do need them to drive their own learning. They have their EPAs. They have to identify where they are at with their different EPAs and what they need feedback and learning on. And then you need to look at that 2 WBAs obviously can be shared amongst all the different consultants, potentially consultants at other hospitals. You will have to look at your 7 registrars or 8 registrars. I think they've got 30 in Ops and Gynae. If they both need 2 WBAs, how are we going to make that happen? And be sort of being able to share up the love in terms of senior MOs in your department, experienced nurses in particular areas, and looking at who can help us actually create all these opportunities for feedback. And I think that's the way we have to view the WBA. These are all opportunities for us to give the registrars feedback on their performance. And the registrars need to make sure that they chase those 2 WBAs a week. So we've been really struggling with our registrars to actually get them to do this. And I was just speaking to Prof. Adene as well, is that we might have to build in a set time that you have to meet with your registrar, even one of us just meeting with them once every 2 weeks for half an hour where they have to present a case. And then they get opportunities to meet with different supervisors, but they have a set time, even if we do it early in the morning, before the morning meeting, and they have some sort of way of creating a habit of WBA within the department. Somebody was also asking, do they have to be planned? So do we have to decide we're going to do a WBA and I'm going to come and observe you? In reality, you're going to try and make use of these ad hoc opportunities. So if you've assisted somebody in theater, if you were next to them in a resus or an emergency medicine, all of those are opportunities for WBA where you can decide at the time, I'm going to give this registrar feedback, let's make this into a WBA. And then you can also have more structured, okay, you're going to do a journal club presentation. We will always do a WBA on any presentation that you do. There will automatically, a WBA will be built into that, and we'll always give you feedback at the end of that. So we need to start looking at how we grasp the opportunities. And the idea with the tool is to make it easy enough that literally if the registrar has just discussed a case with you, you've done a little quick discussion, that they fill in the tool right there and then send you the link, and you literally can fill it in 5 minutes within a day or two to make sure that those things all get clogged. I would like to make the opportunity, and again, we desperately need your feedback. So I've got the feedback form there, and I'll put the link in the chat as well. Just trying to get it to go out. Oh, sorry. Oh dear. Okay, hold on. Let me share that QR code again.